Much. Thank you, everyone. Okay, I'll do the reverse way. I'll start off with the summary so that you only need to see these slides and you'll get a gist of what I'm going to talk of. So this has got a level 1A evidence, that is meta-analysis of 11 randomized controlled trials, that immediate post-operative intravesical chemotherapy reduces the recurrence rate by 35%. If you were looking for numbers, from 58 to 44%, and the number needed to treat is one for every recurrence. 7 patients need to be treated for decreasing one recurrence. So that is, you have to be giving it because the level 1A evidence is there. When to give it, the earlier the better. Once you have done the resection, the earlier the better. When not to, bleeding and perforation. What are the drugs? Any of the drugs is fine. MMC is a good option and it is easily available. How much? Majority of the time they have used 40 milligrams in 50 ml saline for 1 to 2 hours. But we'll come back to discuss these things in my next slides. So trying to give rationale for what I have said, when to give, time and place. If you were looking for place, what are the indications for giving it? All the low grade TA, definitely you give it. And even for the intermediate, you have to consider giving them. Okay, so all low grade, you have to give. All the low risk tumors, you have to give them. Intermediate risk, I'll come back to it in my last part of it. Intermediate risk, you do give the adjuvant chemotherapy, but the overall efficacy is a bit limited, mainly with respect to the maintenance element of the mitomycin. Time, because the intravesical chemotherapy tends to work by killing tumor cells, it has to be given when they are still in and around the bladder. Has got an ablative effect as well, prevents implantation. And if you delay it, what happens is these cancer cells go and implant on the normal looking mucosa, and then they are covered by the extracellular matrix within few hours, because of which the chemotherapy would not be able to penetrate and kill these cells. So when would you give it? Immediate, within few hours. I give it within the next half an hour following resection. I tend to give it in the theater. And when you look at the trials that have been done, immediate plus maintenance, so giving one immediate and the maintenance is superior to giving one at 2 weeks and maintenance. So the immediate one seems to be the critical thing. The maintenance is a different thing, but the immediate is the key. And when you look at intermediate risk ones, you need to give immediate and then a maintenance, which is 6 weeks of induction followed by monthly for 12 months. That's what is the protocol that has been suggested. What to give? You can give anything that you can.
मैसेज कर दो, मेरा भी सेशन चले जा रहा है, अभी खत्म नहीं हुआ, अभी आध पौन घंटा और
Similar
लग
for
जाएगा।
epirubicin, but the commonest one is the
आप
mitomycin and epirubicin. Intravesical gemcitabine, when it has been compared with placebo, i.e. they didn't give anything, gemcitabine was effective. However, when gemcitabine plus 24 hours of saline irrigation was compared with 24 hours of saline irrigation, there wasn't any difference, almost suggesting that intravesical saline irrigation does tend to prevent this implantation. So it is efficacious in case if you can't get hold of chemotherapy. MMC is the most studied and well tolerated one. How do you optimize it? And probably this is the most important slide. We can increase the concentration of the drug to 40 milligrams in 20 ml. That's the first thing. Alkalinize the urine the night before and the morning of the surgery and 30 minutes before commencing the mitomycin. Decrease the drug dilution. I normally ask the patients to come nil by mouth whenever I'm doing it. So for 8 hours, you can ask them to restrict the fluid intake. Of course, you would put, whenever you put a catheter, you empty the bladder, and 2 hour dwell time is what is considered. Rarely do you have side effects from the mitomycin. So I think going up to 2 hours is a good idea. So if you do these 4 measures, it is much better compared to not doing any. When not to give it, as I said, deep resection, bladder perforation, bleeding, and efficacy only in, this is the last one that I just wanted to highlight a bit. So this one was a URTC study 30911, and what they did is 92 to 97, almost 1,000 patients. If you look at this, almost 90% of the patients were low and intermediate, or the overall one were intermediate risk. So 62% of these patients were intermediate risk, 38% for high risk. And when you look at it, they compared epirubicin versus BCG versus BCG plus INH. All had maintenance. I'm just going to come to few things. So these were 80% of them were intermediate risk bladder cancers. When you look at recurrence, BCG is better compared to epirubicin, and all of them had maintenance. You got to take note of that. And when you look at distant metastasis, BCG is better compared to epirubicin. Death from all causes, of course there would be death from bladder cancer. Again, if you look at it, epirubicin one was 1, BCG was 0.35. So whenever these are intermediate risk bladder cancers, do consider BCG if they are able to tolerate. Coming back to the summary, as I said, immediate treatment is necessary. Number needed to treat is 1. You need to treat 7 to decrease 1 recurrence, and when the earlier the better. Don't do it when there is a perforation and in intermediate risk. Definitely they need maintenance with mitomycin, but if they are young patients, they want to preserve their bladders, do consider BCG in this risk group. What any of the drugs will be fine, and the higher the dosage, so you can add 40 milligrams to 20 ml, and that might be better with a retention time of 2 hours. Thank you very much.
Thank you, Sanjay. Is there any role of using hyperthermic mitomycin in the immediate setting?
No, sir. Because hyperthermic mitomycin, that has been the whatever has been published in comparing in high risk bladder cancers. It hasn't been used in the low and intermediate risk bladder cancers. That's one. And then the second is the one that is available in India, the HIVEC, which is when you heat it outside the bladder, has got only a poster evidence. There is no published evidence of that.
Thank
Sanjay,
you.
Sanjay, sorry.
Yeah,
Arun.
PP, you can, yeah, go ahead.
Sanjay, when you said BCG, that means only maintenance after using mitomycin, isn't it?
No, sir. So
Huh.
you give adjuvant mitomycin, and then you go down the BCG 6
Correct,
weekly, and then go down the maintenance
correct,
BCG.
correct. So it is
That's
not
what.
the immediate BCG, it is
No, no,
BCG
there is no role for
follow
immediate
mitomycin.
BCG. No, sir.
Thank you, Sanjay.